This is video number 5 in the week 2 lessons on growth and development. And we're talking about brain disorders. And right now we're talking about cerebral palsy and what causes it. And I said on the previous video, birth injuries, lack of oxygen at birth, subdural hemorrhage, infections, lead poisoning, head injuries, kernicterus, which is, if you don't know, it is severe jaundice. And what happens is the bilirubin is, traveling through the bloodstream and we're trying to get rid of it. But it becomes so built up that bilirubin actually transfers out of the bloodstream and into brain tissue. And when that bilirubin transfers into the brain tissue, it's poison in the brain and causes cerebral palsy. So there are no two cases that are the same. And it all depends on how much of the brain is damaged as to what deficits the child will have. Quite often it's anoxic and can affect the whole brain. Other times, like I said, if it's a brain injury, a head trauma, it might just be a certain section of the brain. What you see early is reflexes that aren't adequate. The child might be very stiff or the child might be extremely floppy. Either way, depending on what's wrong. As the child grows, they don't have control of their hands or their body. They have trouble feeding. They can be very fussy, very irritable babies, and they don't meet any of their milestones. And this kind of stuff, usually, if it's a birth trauma that caused it, it usually starts to rear its head right at birth. They start to see some issues. And again, early intervention is always the key. There's two different kinds. There's spastic and athetoid. Spastic is 65% of all the cases. The child will be very tense, very jerky motions. Legs tend to be crossed. They have some emotional and behavior problems. And then athetoid is like 10% of cases. Involuntary movements. They move with no purpose at all and pretty significant emotional and behavioral problems. You can see here, this is a really good slide that really just explains hemiplegia, paraplegia, diplegia, quadriplegia. And this little slide can be used not only for pediatric information, but for adults as well. Hemiplegic, that means one side of the body is affected. Paraplegic, it's usually the legs, or maybe if it's diplegia, they might have like some problems up in the respiratory cavity, or maybe like one arm, but usually paraplegia means the legs. And then quadriplegia means there is effects on the legs and the arms. And all of this has to do with what part of the brain or spine is damaged. Will determine which of these categories the patient falls into. So how do they diagnose cerebral palsy? It's diagnosed by signs and symptoms. Sometimes the child is several months old. Sometimes, like I said, they start to see signs almost immediately at birth. And they do an EEG, which looks at how the brain is actually sending signals. And then sometimes they do a CT to see what kind of damage has been done. You can see this little girl. She's adorable. There are all kinds of treatments, surgeries, prosthetic devices, occupational therapy, speech therapy, medications, all kinds of things to help these kids. And of course, the goal is to make the child as functional as possible. And remember, every child has the right to an education. So education starts for these young people very early because early intervention is the best. Sometimes kids that have cerebral palsy have other issues, sensory deficits. You know, they might not hear well, they might not see well. A lot of them have feeding difficulties with swallowing, the use of their tongue. Their teeth tend to not grow right, and they have a lot of like bite problems. So grinding and things that just exacerbate dental issues all the more. Sometimes they have bowel disturbances, constipation. They have very poor bowel and bladder control. They're diapered a lot longer, sometimes permanently, depending on what's wrong with them. Um, because of the inappropriate musculature, they don't always breathe well, so they're at risk for chronic respiratory infections. And then again, you know, if they're not mobile, if their legs are crossed in the same position all the time, um, they're at risk for a lot of skin problems. So you got to be really careful to make sure that you're caring for these kids appropriately. Here are some assistive devices that really help. You can see they can prop the child up, let their feet dangle. You don't want foot drop, and this is a really good one where they prop them up so that they can still play, but they're not laying flat on their back. When they're wheelchair bound, they have protective devices for their heads, for their bony prominences. A lot of the rules that you know from treating aging people, um, they're the same. It's just a different reason why you are doing range of motion and why you're turning them and why you're using these kind of assistive devices. Same concept, just a different reason. And the last thing we're going to talk about is Down syndrome. These kids are awesome. Um, if you get the chance, in Lancaster County, there is an organization called the Friendship Community, and they have a gallery called the Friendship Gallery. And that art gallery is completely the work of children or adults with developmental issues. There are a lot of Down syndrome artists in that community that do phenomenal work. So do yourself a favor, and if you can, go to the Friendship Gallery. It's a fantastic place to go. And if you can't go there, then certainly look it up on the internet, because the friendship community is um, taking these adults with developmental delays, and they are finding the artist inside of them. They're tapping into skills and um, talents that no one knew these people had. And they do have a lot. But back to the child with Downs. They have an extra chromosome. And so chromosome 21 is affected. And the clinical manifestations, these little guys, the first thing they notice is they don't have this crease right here. They only have one. And that makes a significant difference in how their hands look. And they can see that usually at birth. They have a separation in their eyes that is different. Their tongue protrudes. They're hypotonic, so that means that, I don't mean that in a fluid way. Hypertonia means they're floppy. They just don't have any ability to be flexible or to flex like they should. And all of the facial features and the hands and all that's okay. They can live with that. However, they have a lot of congenital heart defects, digestive problems. They're at risk for leukemia, hearing loss, hypothyroidism. So there's a whole lot of comorbidities that come with Down syndrome, specifically and most importantly, the congenital heart defects. So what you're going to do with a Downs baby, first of all, you're going to support the parents, because they're probably devastated if they didn't already know. They're going to need help from a lactation consultant. If they're breastfed, they're going to use some special techniques to breastfeed. If they're bottle fed, they're going to use special nipples and different things to help them. A lot of times, Down syndrome baby, their suck reflex is not really good. So it's much easier to suck from a bottle than it is from a breast. So a lot of times, if they really have weight gain problems, they'll have the mother pump her milk, but then give it to the child in a bottle. The baby gets the same nutritional um, benefits of being breastfed, but gets the calories that they need. Um, and that seems to help sometimes. They, just like any other child with any disability, early intervention programs for language and speech and education help. And one of the big things they have to do is control obesity. Down syndrome kids have a propensity to be obese, and that only leads to more problems with their little hearts. Their lifespan is limited, but not nearly as it used to be. Actually, I had a friend who went to my church, and her sister was Down syndrome, and she was the second or third oldest survivor of Downs, and when she passed away, she was 72. And that was pretty old for a Downs patient. Um, but now they are living longer, some beyond their fifth decade. Used to be like the 30s, and they always look much older than they are. What you want to do with a Down syndrome child as they grow is you want to make them as socially independent, physically active as you can. There are education programs that are available. There are a lot of programs for adults, like I talked about the friendship community, but there's also um, work situations that they can do to make them independent. Because you got to remember when you have these kind of patients that mom and dad aren't going to live forever to take care of them. So from birth, they have to start a plan for what's going to happen with this child as they grow up. And if a Down syndrome child is in the hospital, of course, encourage the parents to stay. Eh, Warn the child, visit with if they're admitted for something that's planned, you really want to talk to the child before they're admitted. Maybe give them a tour. Um, Down syndrome kids are very social, so you want to keep them with you. If it's possible to have them out at the station with you, or do your work in their room. Again, parents, family activity is the best. And always, always explain procedures. Just because they have Down syndrome doesn't mean it's not their body. And especially the older they get, you really want to help them. So that's it for the lectures on growth and development. This was very quick, very down and dirty. We will, of course, work more in class, but this just gives you kind of an overview of what to expect. I encourage you to create your own learning tool or chart for Erickson and Piaget. There is one in your packet. It has tons of information. You don't need all of that information. You need to break it down to a few sentences that would allow you to be able to answer a question. And we will work more on this in class. Thank you so much.